Good evening, everyone. Chinmay has asked me to talk on cruciates. I guess most of us are seeing, if at all we are venturing into the MSK reportings, we would be finding that ACLs and PCLs are the bread and butter type of structures, which would be uh, thrown to us every now and then. And with high-end sports, I guess that has become more and more common. ACL, as I always found that whenever I used to find it, that a complex tear or a full thickness tear was more easier. But once the partial thickness tears used to be in picture, the complications or say sort of confidence level used to be on a lower side. So I usually have a practice that I would always talk about some basics on that. They are mostly considered as intra-articular, but they are extra-synovial. They are primarily responsible for providing the stability of the knee and various forces which would be resisted by the integrity of this ligament.
Sorry, sir.
Primarily,
Can you just increase your volume a bit?
yes. Just a moment. Better now?
Yes, sounds better.
Right.
Thank you.
Uh, yeah. So I would always prefer that basic of that should be considered once we are dealing with the length and the width of that ligament, because somewhere when there would be partial thickness tears, we may find that the ligament has excessively increased in length, which is more like a confusion whether we are dealing with a tear or a laxity of that ligament. So we may be knowing that the part of that length and width for our documentation purpose, but not for every now and then. If I'm reporting a patient, I would not go over with the scale or start measuring it, but just for information. Once we are dealing with that, we should always know that where we are measuring that. The axials are the ones which are preferred for measuring the width of that ligament, and preferably the PD weighted non-fat suppressed images or the T1 weighted images are preferred to measure that. The objective of MRI is to ascertain the diagnosis with which a clinician has already suspected. So he is expecting further more details on that, whether the tear, what type of tear, the gradings of the tears, and the associated injuries. Because most of the time, the treatment which is offered for the ACLs, I guess the failures happen because of the missed other additional injuries happening to the other structures which are playing a vital role here. So for MRI, we usually expect that we should be knowing the anatomy of that ligament, and being a ligament which is attaching the femur and the tibia, we usually find that the sagittal image is more preferable to see the entire ligament. There are two bundles which are there. They are named based on their attachments to the tibia. So there would be the anterior bundle, which would be the anteromedial. It is more close to the femoral notch, and the posterolateral bundle is posterior to the tibial attachment, and it goes obliquely and more posteriorly. We may find that the axial images help us more. We will find the posterolateral bundle slightly not that close to the bone, and the anteromedial bundle will be more closer to the bone. So we can appreciate the anatomy, and there is some sort of connective tissue which would be separating them. They would be better visualized either on a T1 or a PD non-fat suppressed image. Uh, So I would always prefer to see in all the three plays, because that gives me a bit of confidence and I can trace that those bundles back and forth.
Sir, sorry to interrupt. It's still a bit low. Can we? Uh,
I've already increased.
Maybe you can just remove the headphones and it might work better.
Am I audible now? Better?
Perfect. Yeah, this sounds great. I think better. For
Okay.
me, it was always fine. I don't know what's the problem with the audience.
Okay. I should be like that. Okay, so once I have that practice to see all the three planes, to go into that details of the ligament back and forth in all the planes, and then see the image. The topmost cut, which is at the level where the intercondylar notch is, say, the summit of that is there, we can find only the anteromedial bundle reaching to that top level. The posterolateral bundle would be somewhere inferior to that level. So we would be again getting a bit of that orientation that the ACL has two bundles and they are having the AM and the PL bundle, which would be having their orientations based on their relations. We usually expect that the PL beam appearing more as a dominant one, where it would be having more darker shade, and the AL bundle, sorry, the AMB bundle would be having more gray signals. I would always prefer seeing the ACL in a coronal plane. It gives me a bit of that confidence to see the entire ligament in a plane where I can trace it. I can see that ligament going from the tibial end to the femoral ends. This is the AMB. This is the AMB seen in a slightly more posterior section, and the PLB, which is a PL bundle, which is seen slightly more after one or two sections, and then it would be appreciated better again when we go slightly more inside the knee joint. Here, if there is some separating tissue, edema, or congestion of the vascular channels, those two bundles would be appearing split and they would be appreciated better. Uh, the ACLs are prone for injuries due to high-end sports. Most of the ACL injuries are seen in young individuals and or in athletes. The middle-aged ones would be finding it once they start some athletic activity. They may find that the insufficient ligament may give way, and then the injuries may be found in them. The usual common spectrum, what we usually see is the full thickness tear and the partial thickness tears. These are the presentations where we will find a lot of hemorrhagic effusions happening in these patients because they are fed by good amount of and they being fed by the vessels as well as they being extra synovial. So many times the effusions or hemarthrosis on a higher side. I usually prefer seeing the ligament in both the sections, both the sequences. I would prefer to see it a PD fat suppressed as well as a PD non-fat suppressed because that would tell me some more detail which would subsequently understand. The ligament tears are usually the ligament tears are usually labeled based on their femoral attachment. So this would be the proximal ligament, this would be the mid segment of the ligament and the distal. So if I'm labeling a tear, I would be using that. There is a proximal tear, a mid substance tear, or a distal tear of that ligament. Uh, the the issues which usually we encounter are with the subtle tears or partial thickness tears or tears which are of lower intensity because clinically they may be symptomatic but they may radiologically be not that evident, like in these ones where I am seeing a very fuzzy ligament. I can see the that the presence of the ligament is there, but the integrity or the continuity of the fibers is doubtful here. On the other side, we are seeing a relatively insufficient ligament. I am not very sure whether there was a previous tear in that patient where we would be finding some sort of incompleteness of that ligament. So here are these type of cases where the clinicians would be expecting a lot of answers. He would be expecting a lot of information, and yes, we would be finding it challenging as well. So the partial thickness tears are the most difficult to assess than the complete tears. As literature says that the sensitivity of the MRI for partial thickness tears and the specificity is on the lower side. So that suggests further that yes, they would be throwing a lot of challenges to us when we are reporting. The presence of a signal within a ligament is termed as interstitial injury or a grade 1 injury according to the classifications. But as we know that there is some sort of intrinsic signal within the ligament, so if there is no active history of trauma or twist in that patient, we may not be in a position to label it as a tear. But if there is a trauma or any sort of injury, then presence of any interstitial injury can help us to put it into a grade one type of injuries. A partial thickness injury where there would be tear, some sort of laxity which would be seen in that ligament, it would correspond to a grade 2 type of injury. And some or the other time we may be using, or interchangeably we are using, high grade or low grade tears. They are based on the cross sectional area, how much area of that entire ligament is involved in that tear. So for that, we usually prefer an oblique axial image. So I'm telling you in terms of a graphic, where the oblique axial image will give the cross section of the ACL. And based on that, I would say that if the tear occupies more than 50% of that bulk, then I would be putting it as a high grade tear. And if it is somewhere less than 50% of that involvement, I will put it as a medium grade. And if it is less than 10%, then I will try to put it as a low grade tear. As there would be some other supportive evidences which would be helping it us further to label these grades based on the pattern. So let's try to see some more details on the partial thickness tears of the ACLs, or what we are usually confused with high grade or a low grade tear. So the partial thickness tears, if they are accompanied by bone bruises, they usually would be higher grades, and they usually would be having a greater risk to progress to complete tears. High grade tear, again, if at all there are other associated injuries like meniscal tears, ligament injuries, or osteochondral fractures, then they would be again classified, or they would be having those categorical classifications towards a high grade type of tears. Uh, Partial thickness tear usually be either seen in one plane or two planes, but we should always try to see if at all we are wanting to label as the cross sectional part. Then I would always prefer a transverse or an axial cut rather than a sagittal image, because in anteroposterior dimensions the ligament usually appears normal or relatively bulkier, but in a transverse dimension we would be in a position to see the actual area, how much that entire ligament is occupying. The absence of any bundle would be termed as a single bundle injury, and it would be again correlated towards unstable or a high grade type of injury. So that usually would be the supportive evidences which would be provided to us if we are labeling, say, high grade or a low grade tears. There are some direct signs of ACL tears, and there are some indirect signs of ACL tears. So the direct signs be pertaining to the direct injury to the ligament or the distortion in the morphology of the ligament. So what we be finding is there would be change in the morphological features of that ligament, and we may find that there would be increased bulk, there would be increased intensity, the ligament fibers would be discontinuous, there may be alteration in the fiber pattern, so that may give a downsloping. There may be some other additional features which will be helping us to identify, yes, the ligament is absent there. So the direct signs would be primarily dealing with the ligament per se. The indirect signs would be the concomitant supportive structures which would be getting injured, and they would be reflected in the form of multiple other smaller subheadings. But they would be helping us to suspect that yes, there would be a possible sign that the ACL is injured. So presence of all those 7, 8, 10 parameters, if they are there, then we should always be suspecting that there is a possible ACL tear. These would be always helpful to us when there is a partial thickness tear, because they certainly would be helping us to put the diagnosis together. So the first one, the like I would be dealing with the ACL tears, the direct signs. So we may find that the initial ones would be presence of a discontinuity of the ligament, like what we will always be finding, that the discontinuity of the fibers is the first parameter which we will be seeing. That we may find that there would be a bit of downsloping of the ligament. So if there is a complete downsloping of that ligament, we are through to say that it is a full thickness tear. But there may be some partial thickness tears where some fibers are still holding the ligament. So the little bit of alteration in the angulation or say downsloping happening again helps us to put that there would be a say partial thickness tear. And somewhere the partial thickness tear, if it is involved in a single bundle, then the life becomes a little bit difficult, where we may require some additional help or some sort of additional features to come to a conclusion. Here, presence or absence of the say the discontinuity of that ligament, which would be the primary feature of a partial thickness tear. So that would be needed to be seen with some parameters, and that I usually prefer using the Blumensatz's line. Primarily, it helps us to understand the orientation of the ligament. Normally, the Blumenset's line and the steep angulation of the ACL, they converge towards the posterior superior aspect, and that orientation would be suggesting a normal orientation of that ligament. The usual, as this is primarily helpful when we are dealing with tears which are from the femoral end, so they certainly help us understand the anatomy. So once the ligament is torn from the femoral end, this relationship is altered. Like in this case, I am trying to plot the same Blumensatz's line, and I am trying to plot that line along the longitudinal axis of the ACL. I can see that the relationship of that the converging angle has reversed, and that is certainly suggesting that a torn ligament would always try to downslope, but primarily it should be tearing from the femoral end, and that's where we can apply this principle. Next comes is the use of the Blumensatz's angle. As we again saw that the converging points where the Blumensatz's line and the longitudinal axis of the ligament is converging, that is forming an angle that is termed as a Blumensatz's angle. Normally, we expect that it would be around 15 degrees. I'm again repeatedly saying that I primarily, when I'm reporting, I am not using these all angles, but it just is for getting or building up that confidence that are we dealing with some tears. That's why I'm uh, 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 explaining it. So the normal angle is directed superiorly and posteriorly. And in an abnormal case where there would be a tear from the femoral end, we will find that the ligament is downsloped and the angle is reversed. So the abnormal angle would be pointing anterior-inferior. Next comes is the PCL sign. Again, we use it to understand the relationship of the PCL and the ACL. Here, a normal longitudinal axis of the PCL should be passing or intersecting the medullary cavity of the femur, and that would be termed as a normal PCL line. But in abnormal cases, the longitudinal axis will flow tangentially outwards, and it would not pass through the medullary cavity of the femur. So this would be again suggesting that this is a positive PCL sign, which would be helping us to put across that there would be a possible ACL tear happening. Next comes are the bone bruises. As I described earlier, that presence of a bone bruise or a marrow contusion or a fracture would be helping us to build up that confidence that we may be seeing a torn ACL, which may be partly torn or which may be completely torn, but the bone marrow pattern, which usually would be seen in an ACL tear, would be classically that pivot shift where there would be contusions of the lateral femoral condyle and the posterior lateral tibial plateau, which would be a coup injury, and then there would be during the repositioning there would be the marrow injuries happening along the medial femoral condyles, which would be again seen. So there would be a counter coup pattern. So I always prefer to see it in a coronal plane. I would find that the presence of the marrow contusions, and I would use the sagittal plane also to identify the coup and the counter coup type of marrow contusions. And this type of marrow injuries, which would be if the intensity of the trauma is on a higher side, there would be an impaction fracture, which may be common accompaniment when we are dealing with the ACL tear. The hyperextension injury again is another pattern where we may find similar bone contour, similar involvement of the femoral and the tibial condylar surfaces. They would be seen in a higher degree of intense trauma or intense injury, where the the condyles they would approximate, and there would be significant injury to the other associated structures in addition to the ACL tears. Hyperextension injuries, as I said, they would cause a lot of damage to the capsule. There may be concomitant tear of the PCLs as well. So the footprint sign, which would be again helping us to identify presence or absence of a tear. In a normal case, we usually would see that the tibial intercondylar eminence is covered by the anterior tibial intercondylar eminence would be covered by the two bundles of the ligament, the ACL ligament. And in case of tear, that emptiness would be shown up, and we can appreciate that on a coronal image. When we go back and forth from the anterior to the posterior, we may find that whatever the bundle, if it is involved, we may find the defect, and that would be occupied by either a fluid signal or connective tissue which has come out there because of the trauma. So that would give that classical footprint sign where there would be an emptiness evident there. Next comes is the gap sign. Normally, we expect that the femoral intercondylar notch, the ACL bundles would go and be very close to the bone cortex. If there would be a trauma, and if it is a full thickness tear, that entire ligament bundle, which would be evidently seen in a normal case, is not there, and that would be occupied by fluid intensity or a connective tissue which has come up because of a trauma. This would be appreciated in all the planes, majorly the coronal and the axial planes. We can appreciate that. So the empty notch would again, or the gap sign would be again an indicator of a torn ACL. So let's talk about the gradings. As I said, presence of a signal intensity within the ligament would be helping us to put it as a grade 1 injury. But we need to take care that presence of normal intrinsic signal within the ligament, or if there is no active trauma or no history of twist given by the patient, then the classifying it as a grade 1 injury would be controversial. So we need to always look at some additional features of, say, like here I can see confused phosphorus fat pad. I am seeing some sort of marrow edema here, and there would be evident signal between the two bundles. We would be thinking of towards the grade 1 type of injury. Here, the ligament continuity of the fibers is maintained. Next comes is the grade 2 type of injury, where there would be increased laxity of the ligament. Here, we may find that the ligament, which is usually taut, here it appears more wavy. We can still appreciate the integrity of the fibers maintained. We can appreciate presence of any change in the intrinsic signal using the axial or the coronal planes. We can appreciate presence of the swollen or the distorted fibers. Here, the increase in the length is evident on the sagittal plane, but if you try to see that, the signal intensity is more lost, and presence of incomplete tears which will give rise to such type of signal intensities within. So lax ACL would be subclassified as a grade 2 type of injury. Here, the laxity of the ligaments would again be an indicator that we may be dealing with a low grade tear or single bundle injuries, where one bundle is torn and the other one trying to hold or put the ligament integrity uh, visually on the images, but the functional integrity is lost. So this brings me to talk about the single bundle injuries. We usually expect that the anteromedial bundle and the lateral bundle, they would be helping us to understand the anatomy well if we are looking at all the three planes. There would be a lot of overlap when there would be a single bundle injury. So I cannot say that a single sequence would be helping us to put the diagnosis. I would always look at as I said, I'm repeatedly saying that I would use a PD fat suppressed image and a PD non-fat suppressed image to look at the image, look at the information. So here I'm trying to show a PD fat suppressed image and relatively intact appearing ligament fibers. But as I go close to the Blumenstein's line, I can see a little bit of lost integrity of that anteromedial bundle, and there is an indicator which would be in the form of a marrow bruise, which is suggesting that there is a possible or a tentative AM bundle which is torn. We can appreciate the presence of that torn AM bundle, as I already talked about, that the ligament, that bundle would be very close to that bone, and if it is torn, we can appreciate that tear very well. So this is a single bundle injury involving the AM bundle, and we can still see that if it is torn at a different level, so we can go back and forth in a coronal plane, we would be in a position to appreciate that the anteriorly placed fibers are torn and the helping hand is provided by the marrow edema at the tibial intercondylar eminence. So this would be the AM bundle, which would be, if it is torn, we would see it in this pattern. Next comes is if at all we are dealing with a posterolateral bundle. Again, I am seeing a fat suppressed image. This is the AM bundle, which is intact, and I can see the PL bundle wavy and it is lax, and I am seeing that it is more slightly appearing subluxed. So this is again would be better appreciated in the other two planes as well. The presence of the lax ligament or a torn ligament, I would always use the coronal plane, as I have told you earlier, that coronal helps me understand the orientation as well as I can trace the entire length of that ligament. So they usually would be appreciated using all the hallmarks which we discussed, that the direct and the indirect signs like gap sign, footprint sign, or say the presence of marrow contusions. Full thickness tears, primarily they are happening at all levels, but we would be seeing as we understand that the proximal, mid, and the distal fibers are the nomenclature is based on the femoral attachment. So let's talk about the full thickness tears from the femoral attachments. I'm seeing a completely torn ligament. It is all downslope. I'm seeing that a lot of soft tissue edema and a lot of hemorrhagic effusion there. So this is a full thickness complete tear. And if I see a ligament, which is again a full thickness tear, but at a later time. So I'm talking of say a few days later, we would be seeing a little bit more information about that ligament, and we can see that the ligament is actually fragmented at a few levels. So we may find that acute overwhelming information, which would be day 2, day 3 of the injury, and this may be day 10 plus if we find a little bit of more better information of that ligament. So, based on the attachment or based on the part of that ligament where it is torn, so the So the proximal is 43%. That means towards the femoral end, and the distal, that means towards the tibial. So there it is 5%, and about 52% of ligament injuries are mid-substance tears. So once we understand that we are utilizing the sagittal plane, we would be trying to appreciate what is that ligament part which is torn, and based on that we are needed to understand or give the information of that distal remnant length of that total ligament. If you are dealing with an arthroscopy surgeon, he or she would be asking information about the length of that remnant ligament. And this is important because the gradings, arthroscopic gradings, are based on how much is the length of that remnant ligament. So, for example, if it is torn from the femoral side, so the torn distal, the ligament which is distal to that, if it is more than 90%, then it is termed as 90% type 1. And as and when as the length decreases, the types are vary. So there are some 4 or 5 types which are based on that remnant length we need to describe in our reports if we are dealing with a full thickness tear which is happening from the femoral attachment. The mid substance tear, as we discussed, they are about 52%, and they would be better appreciated on all images. We can certainly see them better on all the planes. Coronal planes do not help much because in coronal planes we may find that little bit of discontinuity, and it is having a lot of soft tissue which would be surrounding that, so we may find it difficult on a coronal plane. But sagittal and axials help us better. And as I said, about 52% of there would be the incidence is 52% for uh, the the ACL tears involving the mid substance. So they will be falling in that type 3 where the remnant would be 50-50, or say around approximately around 50%. The tibial side tears, they would be 5%. So we are seeing based on how much, whether it is avulsed primarily from the footprint, or it has taken up a bone fragment, and there is a radiographic classification for that as well, which would be helping us to understand whether a treatment plan can be offered for a particular type of avulsed bone fragment. So if it is say a small bone fragment or a relatively undisplaced ones, they would be categorized as type 1, type 2, and type 3 based on that. So this is again a requirement from the surgeon side, because that would be helping them offer the treatment accordingly. Uh, we may commonly encounter such type of feature. This is a full thickness tear of the ACL. We feel that the ligament is actually subluxed and has gone more anterior, and it has a very distorted morphology. It has avulsed from the femoral end, and it has subluxed anteriorly. So this is going to form that stump, which is going to be seen as a fibrotic or a nodular mass. And these type of patients who would be having these type of presentations of the ACLs, they would be coming with a lot of restrictions of the movement. Primarily the extension of the knee would be hampered, because this would be acting like a space occupying lesion, and it would not allow the extension or the flexion of the knee happening. And the fat suppressed images would help us understand it better. We may find the acute stump entrapment related features, like there would be, say, marrow edema, there would be edema of the Hoffa's fat pad, or some sort of impingement related features. So the acute stump entrapment, which is type 1 and type 2. So if it is a nodular mass, it would be termed as type 1. And if it is like a lip-like projection of that ligament, and there would be a lot of edema or say laceration or contusion of the fat pad, it would be a type 2 type of acute stump entrapment. So we may come across such type of features in the patients. Uh, we can see that type of stump entrapment in a full thickness tear. But in partial thickness tear, because some fibers are still intact, they do not allow subluxation of the ligament, so we may not see the restriction of the extension of the knee. And here again, the HOFA fat pad involvement would be slightly less as compared to the full thickness tears. The acute tears, the subacute tears, and the chronic tears. Many a times we see those MRIs happening in the very acute phase, day one, day two of the injury, which is usually giving a lot of overwhelming information, and even surgeons are not willing to address it. And somewhere after 10, 15 days of rest or immobilization, there would be a little bit of more better information which would be shown up on the MRs. So preferable time of intervention, or say surgeons prefer somewhere dealing with these type of injuries after seeing the MRIs after 10, 15 days. In chronicity, we may find that the complete loss of or resorption of the ligament, which would be again causing a lot of clinical symptoms of insufficiency. So there would be some arthroscopic classifications there, but I would just try to give an overview of that, because it is essential that what we are seeing it on an MRI, do the surgeons find it helpful? And for that, there is grading, which is an arthroscopic grading for the ACL. So based on the, as we discussed, the femoral side tears happening from the femoral end, and as the length of that distal fragment decreases, they are labeled as 4 or 5 types. So primarily, we are looking at this, where the length of the distal fragment, if it is proximal, mid, or distal. Sometimes we may find that it is the entire ligament is in a single bundle, or sorry, it is like a single bundle, and there may be split or there may be fibrillation of that. So based on that, the treatments may change, and we may need to. Sometimes we may come across with full thick, completely torn ligament, but it is appearing very much preserved. So this would be suggesting that the synovial sheath is still holding the ligament in its native position, and these type of tears do well if at all the synovial sheath is intact, because the vascular supply helps heal the tears. So usual information what we provide based on our MRIs is presence of a tear happening from the femoral end. So that would be an arthroscopic correlation of that. Tear of the mid substance, we will see a significantly fragmented ligament and a distorted morphology. And if we see tears happening from the tibial end, we may have that correlative arthroscopic image, and that would be helpful. So what I am trying to put across, if we report based on these type of patterns which I've discussed, it would be a direct help to the clinicians, and they may be in a position to plan their arthroscopy based on the MRI informations. So we dealt with the direct injuries happening at the ACL ligament per se and their manifestations, but the effects of the tear happening at the ACL would be termed as the secondary signs. They are there is a battery of pathologies which are shown in a knee MRI. And if I consider this as a knee, and this is the four quadrants of the knee, and this is the anterior aspect, this is the posterior aspect. So primarily, the posterolateral corner of the knee receives the maximum brunt, or there would be potentially larger injuries happening in the posterolateral corner, followed by the anterolateral corner and the lateral corner. There would be injuries of the medial compartment and the posteromedial compartment, and the least would be seen in the anteromedial. So the spectrum of pathologies will be encompassing the entire all the 8 sides of the knee, but primarily we need to see it that all the compartments are looked at carefully when we are reading that MRI. So based on the compartments, we may have various associated features. So let's talk about the posterolateral, anterolateral, and the lateral compartment manifestations, which will be seen in the ACL tear. The impaction injuries which would be happening in the lateral femoral condyle would be the deep femoral notch. There would be a increased anterior tibial translation. There would be injuries to the lateral meniscus. There would be injuries to the posterolateral corner structures, and there would be injuries to the anterolateral compartment structures as well. So the 7-8 enlisted injuries, if we try to see them, we would we will need a very strategic approach. We cannot jump into any specific thing unless we look at the entire compartment carefully. So let's talk about the bony associations of the lateral compartment. So first would be the impaction-induced osteochondral fracture, which would be seen in the lateral femoral condyle. I told you about that pivot shift marrow contusion, which will be giving rise to a osteochondral impaction fracture if the intensity of trauma is on a higher side. We expect that the depth of 1.5 millimeter and higher would be termed as an osteochondral impaction fracture or the deep femoral notch. We would always expect the same pattern of bone bruise happening and the other areas which would be getting affected. But primarily, we are focusing on what would be the pattern of that osteochondral impaction injury. So a pivot shift marrow follows if the intensity on a higher side to the femoral notch. Next comes is the relation of the tibia with the femur. Normally, we expect that there is a little bit of, say, around some millimeter expected anterior movement of the femoral condyle in relation to the tibial condyle. So this is a normal relation, but when we are dealing with an ACL tear, there would be a tendency of a anterior tibial translation, and more than 7 millimeter of distance between the posterior aspects, the mid tibial posterior aspect and the posterior aspect of the mid femoral condyle. That distance, if it is more than 7 millimeters, then it is termed as a anterior tibial translation. And if you see the literature, it is about 99% specific and about 86% specific, sensitive. uh, the importance is that we should always try to measure this or draw the lines at the mid lateral femoral condyle. If I draw, like in this case, I have shown up that it is a very significantly increased distance, but I have measured it at the wrong level, and this would give the overcalling of that anterior tibial translation. So that brings me to the electrical compartment. So I told you about the deep femoral notch and the anterior tibial translation. The, the posterolateral corner is the most important one. Here we would be primarily seeing the most static structure is the iliotibial band, the anterolateral ligament, and followed by slightly more posteriorly the biceps femoris, which would be having the lateral collateral ligament adjacent to it. The popliteus tendon would be another structure which would be coming into that posterolateral corner, followed by a ligament which would be the popliteofibular ligament. So these are the structures, they are at risk when there would be a ACL tear, and they may gradually undergo tears if the intensity of trauma is on a higher side. So the lateral meniscus and the popliteomuscular tendinous complex needs major attention. So this I would try to do it in a slightly more detail. So the popliteus tendon is having its origin from the posterior aspect of the proximal tibia. It has a popliteus hiatus, and as it goes to the knee, it goes towards the femoral lateral sulcus. In that course, it is in relation to the posterior horn of the lateral meniscus. It has two fascicles which are covering from the superior and inferior aspect. And as we go slightly more towards the fibular side, the popliteus tendon gives a ligament, which will be the popliteofibular ligament, and that would be majorly getting affected when there would be a posterior lateral corner injury. So the first thing would be when there would be a anterior tibial translation, we may come across with subluxation of the lateral meniscus. So in a normal case, if I draw a line tangential to the posterior horn, it will always pass through the tibial condylar surface. And in a normal case, the posterior horn, if I again try to draw a line, it would be either more posterior to that, or there would be a complete posterior subluxation of the lateral meniscus. This is in relation to the tibia. So this would be bringing that uncovering of the posterior horn of the lateral meniscus. Once it is seen, and if it is seen carefully, they may be accompanied by the zip tears, which are termed as the Risberg rip. Primarily, the posterior meniscocapsular attachment and the ligament of Risberg, they are having a connective tissue separating them. But when there would be a posterolateral corner injury, there would be a vertical tear or a vertical peripheral tear happening in uh, the posterior aspect, and that would be termed as the Risberg grip. Very common accompaniment in the ACL injuries. As we gradually see it, we would find that the soft tissue and the meniscocapsular attachment, together with the injury to the fascicular bands of the popliteus tendon, would also be seen, a common accompaniment with the ACL injuries. So the shearing of the posterolateral corner, the popliteus and the lateral meniscus would be seen more efficiently if it is accompanied by fluid supporting or surrounding them. The arcuate ligament, the most important ligament again, because it would be commonly seen if at all there is an injury to the arcuate eminence of the fibula, a graphic telling the lateral collateral ligament, and posterior to that, the arcuate ligament, which would be in the form of a Y band, and that would be seen more towards the fibular end. The other two bands would not be that easily identifiable. Normally, I would take help of a non-fat suppressed image to see that, and I would be in a position to appreciate them. Once we see a ACL injury, we may see indirect signs of the ligament getting injured because there would be some fractures, avulsion injuries happening at the arcuate eminence of fibula. And if it is high velocity trauma, the other ligaments, like there would be shearing of the other ligaments of the posterolateral corner, and there may be shearing of the popliteus tendon from its footprint as well. So this is a complex ligament, but if it is seen carefully, we may be in a position to appreciate it. The anterolateral ligament needs a lot of attention because the surgeons are quite very much interested in knowing the integrity of the ligament. I always will be happy to tell the anatomy first. The ALL, I would say, the ALL is posterior to the iliotibial band. This is the Gerdy's tubercle area, and the iliotibial band. Posterior to that, there is the ligament. I can see that the ligament very well separated from that, and I would be in a position to see the ligament more in detail in the coronal plane. So this ligament, if it is to be seen, we may require a bit of more non-fat suppressed image because the clarity would be visible more better. In cases of injuries, the ALL may undergo sprain, so we can see the edematous ligament. I am seeing a small amount of marrow edema there at the footprint. I may see the partial thickness tears of that ligament. I would be able to see the marrow changes subsequently there. and I would be seeing a full thickness tear, which again would be easily identifiable, and sometimes the complete avulsion with a significant injury to these structures in the posterolateral corner would be there. The next to follow a torn ALL would be presence of a avulsion injury, and there would be a bone fragment which would be avulsed from the lateral tibia, and that would be the Sigon's fracture, which is involving the tibial footprint of the ALL. The important mention is about the Kaplan's fibers. Again, surgeons are very much interested in that. Kaplan's fibers, I was, frankly speaking, I was not aware for a significant amount of time. But later on, nowadays, I'm seeing that the surgeons are wanting some more clarifications on the Kaplan's fibers. So the Kaplan's fibers would be again appreciated better on a non-fat suppressed image. These are flimsy fibers. They have multiple distal and proximal fibers, and they are complex. But the idea is to see them and appreciate them, and regularly try to understand their importance. I usually use a fat suppressed image to see those ligaments, and if it is a good quality image, we would be in a position to appreciate the distal and the proximal Kaplan fibers. Those Kaplan fibers would be uh, surrounded by fat, and they would, if it is they are normal, they would be flimsy and they would be sharply defined. In cases of injuries, we may see, if at all, our technicians have included some more higher up cuts in cases of an ACL tear. We may find the injuries of those fibers. So these are the areas which are affected because of the direct injury to the lateral side, and we can appreciate the torn or the sprained ligaments of the Kaplan's fibers. Literature, this is of 2024. This is talking about the incidence of various ligaments which are happening, and there is a mention of Kaplan's fibers that about 50% of the individuals will have Kaplan's fiber affected. And please note the ALL ligament is about 72%. So the significance of these ligaments is that the failures of the grafts happen if these ligaments are not addressed, and hence the surgeons are wanting information on that. Occasionally, we may see LCL or the lateral collateral ligament and the PCL in the single plane, which is not acceptable. And if it is there, then we should suspect that the ACL is injured. So I started to understand that the LCL is never seen in a single plane, and if it is seen, then I would always take the help of the PCL, because this may be sometimes an oblique positioning. So if this two ligaments seen in the same plane, then we would be dealing with an ACL there. This is again an indirect evidence of a potential tear happening. Uh, the next thing is the posteromedial corner. Posteromedial and the medial corner. It's complex, but if we understand the anatomy, it would be easy for us to understand the structures which are affected. So the tibial plateau, the articular cartilage, the posterior horn of the medial meniscus, the meniscocapsular ligaments, the meniscotibial ligament, and the posterior capsule. They are all compositely forming the structures for the posteromedial corner of the knee. And we usually would be seeing the injuries, or say, in cases of ACL tears, these are the structures which will be getting affected. We primarily expect that the medial meniscus getting injured, so the confusion and the marrow edema happening at the posteromedial corner, posteromedial aspect of the tibia would be helping us see that. We may find peripheral tears happening in the posterior horn of the medial meniscus. There would be sharing of the meniscocapsular attachments, and they would be appreciated together with the ACL tear. So if there is a peripheral tear happening in an ACL, without involving the major bulk of the meniscus, we should always suspect presence of the ramp lesions. Ramp lesions, I would need to mention that because they are a bit complex to identify and are common accompaniment with the ACL injuries. So this is the capsule, the the meniscus part, and the various zones. So if I try to appreciate them, this is the tear of the ligament happening around the superior aspect, the tear happening at the peripheral of the meniscus, the tears happening along the inferior aspect, the tears happening along the entire length, separating the periphery of the meniscus, and there would be uh, tears of the posterior peripheral aspect as well as the meniscocapsular attachment. So based on that, there are 4, 5 types of those ramp lesions, and there is a classification for that. And if I show you the cases, uh, a torn attachment, the superior attachment, the torn attachment together with some sort of peripheral tear of the posterior horn, and there would be another which would be a type 3 tear, which would be having some more part of the meniscus involved. So the posterolateral and the posteromedial corners are important for us to understand. Lastly, is the medial collateral ligament. We may find the tears of the MCLs, which would be complete tear, partial thickness tear, or there may be associated shearing of the entire medial compartment. We usually expect that the informations on the posteromedial corner posteromedial corner to be complete when we are reporting about the integrity of the periphery of the medial meniscus, because sometimes failed surgeries may be seen, and these may be the role players in them. So I guess I have 51 seconds, so I don't think I can reach out to PCL if Chinmay allows me, or I think we'll stop here.
Those you can you wind it? Like how much time will it take?
No,
PCL?
no, I think it will take some time, so I think I may stop here if at all
Yeah,
time.
we'll have another session on BCLs.
Yes, please. Yes, please.
Yeah, thank you so much, sir, for that wonderful and a comprehensive review of the cruciate ligaments, the anterocruciate ligament. I've never heard such a detailed and in-depth analysis of ACL, and there are plenty of signs which maybe even I will start using in practice, which will help in difficult cases. Thank you so much, sir. There are a couple of questions that have popped in now.
Yes, please.
The first one is: can mucoid ACL cause restriction of movements?
Yes, yes, because the actions of the because there would be an increase in the bulk of the ligament, so the functional viability of the ligament is partly compromised. I would not say that it would be completely hampering the movement, but it would be restricted movements.
Yes, sir, yeah. So we do mucoid ACL injections, ultrasound guided
Yes,
restricted flexions, so that really helps them, especially if there's a ganglion at
yes,
femorotibial attachment. So yeah, they do cause restriction of movement, especially abdominal flexion is restricted.
yes.
That's said. So the next question is: we often see degenerative changes in osteoarthritis, like in ACL. Also, the ACL looks either attenuated, some mucoid change. So how do we describe them in an ONE?
Primarily, if we are looking at the ONE, there would be the degenerative changes in form of proliferation of the connective tissue and reduction in the uh, functional fiber. So the ligament bulk would be there would be a reduced ligament bulk. So the the AM and the PL bundle morphology would be reduced. So if I talk about the transverse dimension of that ligament would be reduced, and uh, it may be enveloped by a lot of connective tissue which would be fatty, and that would be again an indicator that the ligament is functionally not great. And in OME per se, I would say that the use of the knee is also limited. So the ligament functionally also is underused, and gradually it involutes towards a later period. So I would say a reduced ligament bulk would be seen.
Okay, thank you, sir. When is the correct time to do a repeat MR for grade 1 injury?
Ideally, it's not recommended. Uh, it's more clinical, and if there is a intrinsic signal, we usually expect that over a period of say 6 weeks, we usually should not be seeing any signal. If anyone, I mean, any clinician is over enthusiastic, he can get an MRI done, but not recommended for a repeat MRI unless the patient is symptomatic for that.
Yeah, thank you, sir. Can you explain the Blumenset's angle?
Blumensted's angle. Okay, so a line drawn parallel to the Blumensted's line, and the longitudinal axis of the anterior cruciate ligament. So the converging point, which is which is the posterior superiorly. So that converging point forms an angle, and that is the Blumensted's angle, which is 15 degrees normally. This is because of the steep upward movement of the ACL, and it tries to converge towards the femoral footplate.
Thank you, sir. Mm, the next question is how important it is to mention POL and OPL tests, the posterior oblique ligament and the ob- ob- oblique popliteal ligament or something. Yeah, I
Yes,
don't
yes,
remember the
very,
name.
very important. Very important. Uh, so the posterior oblique tear, I guess it's posterior oblique ligament tear is very commonly, so it is part of the deep medial collateral ligament complex. So it is commonly associated with ACL injuries, and around 42%, as I am not very sure on the exact number, but I think 40 to 42% of the uh, initial or grade 1, grade 2 type of MCL injuries would be having predominant posterior oblique ligament tears or say sprains. For the oblique popliteal, yes, the lateral band is the most common one to undergo tearing. It is rather it is part of the posterior lateral corner, or it is one of the accompaniment of that posterior lateral corner. So usually it would be seen as torn in the high velocity traumas.
Okay, just a last couple of requests. Can you please show the Kaplan fibers again? And uh, there's one more request. Yeah, I think the Kaplan fibers mainly.
So these are along the lateral aspects of the femoral condyle seen higher up, and they are, if you see this graphic, they are proximal and the distal fibers. So this is the distal fibers you can see. So as if it is included higher up, we can appreciate those proximal and the distal fibers. Partly this is the area of the proximal fibers, and these are the areas of the distal fibers. They are seen in axial planes also quite well. We can appreciate those fibers going laterally. They merge with the capsule and the peripheries of the superior aspects of the retinacular bands. And so those usually would be appreciated better on the axial planes. So these are the vertically oriented fibers. These are obliquely oriented fibers. They are quite randomly oriented, but their aim and objective is to hold the capsule with the bone part, or rather, I guess they are part of that those condensations of the capsule only. Sorry. Right?
Yes, sir. Thank you. Uh, the last question is, how do you differentiate ACL tear versus mucoid degeneration, and which sequencer and plane would be ideal?
The question is about the mucoid degeneration here. The other additional signs which we have discussed, they would not be present. And usual the mucoid degeneration would be bulky bulbous appearing ligament where there would be the continuity of the ligament fibers are maintained, and these type of proliferating mucoid changes, they will try to insinuate between the ligament fibers, but they would never be causing discontinuity of the ligament fibers. On the other side, as we have discussed, there would be obvious discontinuity of the fibers when it would be tear. So mucoid degeneration, the transverse dimension and the sagittal dimensions would all be significantly increased, right?
Yes, sir. Thank you so much. That's all the questions. Thank you for answering them patiently. It was wonderful to have you on this platform, and it felt like you have done PhD in ACL ligament itself.
Oh,
It was such in-depth analysis. We just loved it, and we're getting such positive reviews on the chat as well. I'm happy to share there were more than 270 participants from 36 countries, I guess, and they were all enthralled with the knowledge that you shared today. We hope to have you again on this platform, maybe with posterior cruciate ligament and the collaterals, I guess.
thank you. Thank you.
Thank you, sir. Thank you.
Thank you.
To the participants, do tune in on Saturday and Sunday for